Hello, this is Anjali Kotian from Department of Respiratory Therapy. I am Assistant Professor cum Respiratory Therapist and I am working in Yenepoya School of Allied Health Science, Yenepoya University. So today we will be dealing with troubleshooting during mechanical ventilation. Now troubleshooting during mechanical ventilation is basically going to tell you how to solve the problems that you are going to face when you are mechanically ventilating a patient. So let's see what you are going to go through or what you are expected to know by the end of this session. So you are supposed to identify various types of technical problems that are encountered during mechanical ventilation of critically ill patients. You should know what are the problems and from where they are arising, and basically you are supposed to know what type of alarm situations can arise in a mechanically ventilated patient and how to troubleshoot them. So the content of this session is going to be as follows: identifying patient in sudden distress, patient related problems, ventilator related problems and common alarm situations. So what is troubleshooting? Troubleshooting is nothing but seeing how you can solve a problem in a step-by-step manner. So what happens is, whenever a problem arises, we have to look at that problem and we have to know what is the cause of this and how we are going to deal with this, so that further we are not going to face that same problem again. Now, troubleshooting in the context of mechanical ventilation involves the identification and resolution of technical malfunctions either in the patient or the ventilator system. Now, usually what happens is, whenever there is some problem arising from the ventilator or there are some alarms, very common thing is to do is go and silence the alarm. But we are not supposed to do that because it is going to harm our patients. So let's see how we can troubleshoot the various problems that arise during mechanically ventilating a patient. So how do you identify the patient that is in sudden distress? Imagine a scenario where your patient is on mechanical ventilation. He was apparently fine until when you saw him last time, but suddenly he is not looking fine to you. Now, we say a very common phrase, that is, the patient is fighting the ventilator. What does that mean, that the patient is fighting the ventilator? It is sometimes used to describe an individual who was apparently doing well earlier but now is not fine on mechanical ventilator. Now there can be n number of causes that can cause this. So let's see how you can identify that the patient is in sudden distress, or what are the signs and symptoms that you need to look for. So certain symptoms that you are absolutely going to see when a patient is in sudden distress are use of accessory muscles, patients having tachypnea, tachycardia, gasping, drop in the oxygen saturation, low volume delivery, low minute ventilation and shooting of pressures. So basically you are going to see clinical manifestations in the patient and certain alarm situations that arise from the ventilator and the cardiac monitor that is connected to the patient. Now how do you see a patient is going through this? You can see in this picture given here that the patient is using their accessory muscles. It looks like he is in lot of uneasy way, or you can say that the patient is uncomfortable on mechanical ventilator. So this is how you are going to see. And now let's see what are the problems that can make your patient go into distress. So when I talk about patient is in sudden distress, like I told earlier, it can be because of mainly two categories. Either it is because the problems that are arising from patient side, or it is because from the ventilator's technical aspects. So let's broadly classify this patient related and ventilator related issues. What are the patient related causes are artificial airway problems. Now the patient is endotracheal intubated. So what happens is, there could be some kinking of the tube, or there is some obstruction in the tube. These things can cause the patient to be in distress. Then there is bronchospasm, sudden bronchospasm which you have not seen. They can be seen as the patient in distress or the alarms that are being given by the ventilator. Then there are secretions that are obstructing the airway, pulmonary edema, pulmonary embolus, dynamic hyperinflation, abnormal respiratory drive. This is when you see that the patient is fighting with the ventilator. Alteration in body posture. Ideally, we are supposed to make the patient lie in a 45-degree angle when on mechanical ventilation. But if the patient is not in a proper body posture, there might be kinking of the tube or kinking of the circuit that is connected, or even disconnection. So, we have to look into these problems. And then drug induced problems, that is, if the patient was in sedation and apparently he was fine, like he was comfortable on mechanical ventilation, but now the sedation has weaned off and the patient is again completely conscious and he is not able to resist whatever is happening, or he is not able to go in sync with the ventilation, that is, there will be asynchrony with the patient and the ventilator. So, this can be because of drug induced problems, or there is abdominal distension that is going to cause low volume due to low FRC. Or there could be sudden pneumothorax, that is known as tension pneumothorax. So, these are few causes that we can see are going to cause your patient to have sudden distress. Now, what are certain ventilator related problems? So, basically patient related problems are something that we can solve. We are going to inspect the patient and we get to know, okay, there is something problem with the patient and we can give the appropriate treatment for that. But what about the problems that are arising from the ventilator? So, ventilator related issues are as follows. There could be a system leak. Now, this could be because you have not checked when the ventilator was being connected, you have not checked whether the connections are made proper, or whether appropriate valves are set or not, or all the fittings are properly ensured or not. Circuit malfunction or disconnection. Like I said, there could be circuit disconnection when the patient's posture has changed, or if the patient is fighting with the ventilator, that time the circuit might get disconnected from the ventilator. Or circuit malfunction happens when we have not connected the circuits properly. Inadequate FiO2. Imagine scenario where the patient requirement is of higher FiO2, but maybe the oxygen cell in the ventilator is not working or needs a repair, but you are unaware of this and the patient is not receiving adequate fraction inspired oxygen. What needs to be done that time is either you need to change the ventilator or you need to call the technical engineer so that they can come and repair the oxygen cell. Patient ventilator asynchrony. Patient ventilator asynchrony is the most common cause when we find the patient in sudden distress. This could be because you have kept inadequate settings, maybe your trigger is not set properly, maybe the flow you have set is not enough, or the settings, the pressure support that you have given to the patient is not enough. This most of the time can lead to patient ventilator asynchrony, and which can be troubleshooted by appropriate settings on the ventilator. Inappropriate ventilator support mode. Now imagine there is a patient who is not completely conscious, who is not in the state of mind to breathe or have a good respiratory drive, and you have put the patient on pressure support mode of ventilation. What's going to happen is the patient is going to get fatigued. After one point, the patient will be completely in distress because he is not getting enough breaths. So, even setting inappropriate ventilator mode is going to affect the patient and can result in sudden distress. Inappropriate trigger sensitivity, like I said, if we are not going to set the trigger properly, it can lead to patient ventilator asynchrony. Now, trigger is something that is going to give the patient a chance to breathe, and ventilator is going to detect that breath and then continue the rest of the breath. So, what happens if you have set very less of trigger, every small drop in the circuit is going to be detected as a trigger and there will be breath stacking. Whereas if the trigger is kept at a higher value, you are going to fatigue your patient. The patient needs to take a lot of effort to produce that breath, and that is going to fatigue your patient and cause distress. Inappropriate inspiratory flow setting. Usually patients need somewhere around, adult patients need 60 liters of flow, inspiratory flow, so that they can keep up with the ventilator breath. And if you are not giving the enough flow, or it can vary from patient to patient, some patients because of various disease condition might require less flow or higher flow. So if we are not meeting the enough inspiratory flow demand, then also your patient will land with respiratory distress. Inappropriate cycle variable. Now this is very commonly seen because when we are setting a respiratory rate, we might not give enough time for the patient to exhale out, right? So what happens is, if we are not giving the patient enough expiratory time, the patient feels kind of trapped. He is not able to exhale completely and the ventilator has started giving the next breath. So in this cases, the cycle failure is going to happen, and this can be changed by changing the cycle setting. Inappropriate PEEP setting. So this can lead to ventilator related issues because some patients are dependent on positive and expiratory pressure. If your patient needs higher PEEP and you have not set that amount of PEEP, that means your patient is not going to be able to be comfortable on the ventilator because his demand is more than what you are giving. So setting appropriate PEEP is equally necessary. And there are problems with closed loop ventilation. So nowadays our ventilators are all on closed loop ventilation, that is, if there is any leak in the circuit or if there is any disconnection, the ventilator is not going to get the breath by breath analysis. So what happens is, the ventilator is going to get disconnected and the patient who is completely dependent on ventilator is going to feel distressed because he is not able to take breaths. So these were certain problems that can cause the patient to be in sudden distress. Now we have discussed about the various ventilator related problems and the patient related problems. This is when you go and see, okay, what needs to be done. Before this, there is something also known as alarms. What happens is, usually when you see a patient who is in distress, who doesn't look fine, definitely that patient will have tachypnea, tachycardia or desaturation. But also there will be the constant alarms in the ICU setup, right? So usually what we do, we go and silence the alarm. But the correct way is to go see what is the alarm about and try to troubleshoot it, right? So let's see how we can identify various alarms when a patient is on mechanical ventilation. So the following image gives us a short idea of what all alarms can be seen. So there is high pressure alarm, low pressure alarm. There is high pressure alarm, low pressure alarm, low volume alarm, high frequency alarm, apnea alarm, high PEEP and low PEEP alarms. Now these are the alarms that you are very frequently being seen in the ICU. Let's see how to manage these alarms and how to manage a patient who is going to be in sudden distress. So first thing, when you approach that patient, imagine this scenario, there is an alarm blaring there and you are not able to see the patient, but you can definitely hear the alarm. The first thing to do is go near the patient's bedside and check the activated alarm and make sure the alarm parameters have been set properly. Usually what happens, the alarm limits that we are setting is going to be on the ventilator and the cardiac monitor. So please check that the higher and lower limit of the alarms are set properly. Then once you have checked these things, the cause of the problem has to be determined. Like I told, you have to look at the patient and see what all signs and symptoms are seen, or you have to do a good examination on the patient and see what causes can be determined. And once you know the problem, then you can easily find out, okay, how to troubleshoot this. Now in a scenario where you have seen patient is having tachypnea and tachycardia, you went and auscultated and there were absent breath sounds on the left side. and when you see that there is a high pressure alarm also, what do you understand? Okay, this could be a probable case of pneumothorax. So you need to percuss that area and see if it is pneumothorax. If it is pneumothorax, immediately you are going to do is needle aspiration. In another scenario, if you have auscultated the patient and you can hear that okay, there are secretions, and even in the circuit you can see secretions, that could be the cause, that is obstruction is causing the patient to be in distress. So in such case scenario, what you are going to do, you have to go and suction the airway of the patient. So this is how you are supposed to identify what is the problem, and then take a step back and think what can be the possible solutions for it, and then troubleshoot the following problems. So after you have determined the problem and you have seen okay, what all solution is there or what all treatment can be given to that patient, and even then if you are not able to solve the problem, then the best thing is to change the ventilator or call for help. Now changing the ventilator will help in scenarios where the problem is arising from the ventilator. But if the problem is arising from the patient and in your expertise you are not able to control it, then definitely you need to call the expert so that they can come and identify what needs to be done and how it needs to be done. So what do we need to do if an alarm activates or if you see an abnormal waveform that appears? So assess the patient's appearance to evaluate for distress. Like I told, your patient is in sudden distress. 5 minutes back you saw that patient, he was fine, he was apparently fine, but now you come back and see due to some alarm the patient is not looking fine, the patient is sweating, there is tachypnea, and the patient is fighting with the ventilator. You can see the patient is moving agitatedly. So what needs to be done? Go and check what other problems are there. Check the patient, do a physical examination, auscultate the patient, check the saturation. Once you do all these things, you are going to get some idea that what is wrong with the patient. Ensure that the patient is receiving adequate ventilation and oxygenation. In this scenario, the most appropriate thing to do is something known as DOPE. Now what is DOPE? You have to check for tube dislodgement or disconnection. So that is the first most thing. Please check whether the circuit is disconnected from the ventilator, or if the patient is obviously intubated, so check if the tube is in proper position or not. Auscultate the patient and get the breath sounds. If the tube is dislodged, that means that could be the reason that is causing distress for your patient. If there is disconnection, determine why the disconnection happened, whether the patient's posture changed or what happened. Then there is O, that stands for obstructed system. Now obstruction can be from the ventilator also or from the patient. From patient, if there is pooling of secretions, the artificial airway is going to get obstructed, which will need suctioning. And from the ventilator side, there could be kinking of the circuit, or maybe the circuit has come in between railings of the bed, which can again cause obstruction of the circuit, which needs to be relieved properly. P for pneumothorax. Now like I said, when you look at the patient, you are going to do a physical examination, looking at which you can determine what is the problem. Most of the time, if because the patient is mechanically ventilated and the pressures were not controlled, the patient might land into pneumothorax. So you can take appropriate decision of how to deal with this pneumothorax, either by needle aspiration or by a chest tube drainage. And E, the last one, is equipment failure. So equipment failure is when you have done all of these things, immediately disconnect your patient from the ventilator and manually bag the patient. Meanwhile, your other colleague has to determine what is wrong with the ventilator, so that you can calibrate the ventilator once more and check if everything is proper, or otherwise the last resort is to change the ventilator. So this is the mnemonic that we follow, DOPE, and this has been always followed for patients who are in sudden distress. So there is D for dislodgement or disconnection, O for obstruction, P for pneumothorax, and E for equipment failure. So let's go and see some common alarm situations. I already told you the very common alarms that you are going to see in an ICU setup. Let's see why these alarms come up and how you can troubleshoot them. So the first one is high pressure alarm. Very commonly we see this in ICU. The high pressure alarm is very common in patients with respiratory condition that cause decreased lung compliance or increased airway resistance. Now there are various causes that high pressure alarm could be there. Either it could be because of the patient's condition, in conditions like ARDS, or where we need higher pressures, or there is decreased lung compliance. In such cases high pressure will be there, shooting of pressures, peak pressures will be seen. Or the patient is coughing actively, so that can also lead to high pressure, but this will be only for that moment when the patient coughs. Or there could be secretions accumulation, like I told, obstruction. So whenever there is obstruction, the ventilator is going to give you high pressure alarm. Or the patient is agitated and the patient is biting the endotracheal tube, it can give you high pressure alarm. So if the patient is biting the endotracheal tube, what can be done? You can place a oropharyngeal airway. If there is kinking in the circuit or the artificial airway, again you are going to get a high pressure alarm. If there is impingement of the endotracheal tube on the carina, or there is dislodgement, then also you are going to get high pressure alarm. So how do we troubleshoot this? So these are the following steps that need to be performed. Perform the endotracheal suctioning if indicated. Insert a bite block or pharyngeal airway to prevent the tube biting. Check for a kink in the circuit or the artificial airway. Administer a bronchodilator to alleviate bronchospasm. If there is bronchospasm, then you can definitely administer bronchodilator and the peak pressures will automatically come down. Check the ET position, and if it is dislodged, reposition it. Check for water in the circuit. Most of the time whatever the condensation is happening in the circuit, it is going to accumulate and the water is going to get accumulated in the circuit, which will lead to high peak pressure alarm. Check for the patient ventilator asynchrony. Like I told, if your patient was sedated and now the sedation has weaned off and the patient is not able to sync with the ventilator, he is definitely going to fight, which will lead to increased peak pressures. Or if you have not set the trigger properly, you have not cycled off properly, then these can also cause patient ventilator asynchrony. In this case, what needs to be done is again check the settings if they are appropriate for that particular patient. Check for any malfunction of the inspiratory or expiratory valves. If all of these are proper and still the patient does not look to be fine, maybe you need to disconnect the ventilator and start manually bagging, and also you can change the ventilator. Then there is something known as low pressure, low volume alarms. So low pressure and low volume alarms are very commonly seen with disconnection, or maybe there is some leak in the circuit. So what needs to be done in such cases is you have to check for a leak or disconnection in the circuit, or you have to check for a leak in the exhalation valve. Very commonly what happens is when we are fitting the valve in exhalation valve in the ventilator, it might have not fitted properly, because of which the ventilator is not able to sense it and it will show constant leak or loss of volume, loss of pressure. Check for any loose connections, that is at the flow sensor or at the Y connector or at the cath mount. Check if all the connections are fitted properly. Ensure that there is no leak in the pilot balloon. Take a cuff manometer and check whether the pilot balloon is inflated adequately. Check if the pilot balloon is defaulty. If it is defaulty, then the ET tube has to be changed. Ensure that the endotracheal tube is properly located. Again, if there is dislodgement of the ET tube, that can also lead to low volume or low pressure alarms. Ensure that the endotracheal tube cuff is adequately inflated and adjust the ventilator settings as needed. Now low volume could also be because the patient's demand is higher than what you are giving. So in such cases you need to change the ventilator settings and meet the demand of the patient. Then another common alarm that you are going to see is high frequency alarm, and this is most of the time associated with the patient who is hyperventilating. So a high frequency alarm in mechanical ventilation is triggered whenever the total frequency exceeds the preset high frequency limit. That means If I have set a frequency limit of 40 breaths per minute for a patient, then the patient is maybe breathing at 60 breaths per minute or maybe even 42 breaths per minute. That is when you are going to see high frequency alarm. And this alarm, if you are not going to troubleshoot it, it will lead to the patient being in tachypnea and hyperventilation, which is going to cause excess washout of the carbon dioxide. Now the sounding of this alarm can occur when auto triggering is present due to an incorrect sensitivity setting. It may also be a sign that the patient is in respiratory distress, which means that the cause must be identified and corrected as soon as possible. Now what happens is, whatever I said, if the patient is in pneumothorax or if there are secretions that are blocking the tube or the circuit, what will happen is there will be a sense of choking feeling for that patient, because of which the patient will start breathing faster and faster. He needs more breaths, but the ventilator breath are not reaching him. So what happens, there will be tachypnea, and this tachypnea will be picked up by the ventilator and given out as high frequency alarm. So if you hear this alarm, you need to go and check the patient, and like we have seen earlier how to identify the cause, you need to identify the cause and troubleshoot it. So what and all things can be done to troubleshoot high frequency alarm? Check the sensitivity setting, whether the sensitivity is set properly or not, whether the trigger sensitivity is set properly. If adequate trigger is not set, that means if the patient needs 1.5 ml but you have set maybe 2 or 3 ml, it is very high for the patient and it will cause fatigue. So check the sensitivity. Perform endotracheal suctioning if indicated, that is if there is obstruction due to secretions, perform suctioning. Increase the level of pressure support. Usually what will happen in a case scenario like you are trying to wean a patient and you have put the patient on pressure support mode of ventilation. Now what is going to happen is you have not given adequate pressure support for this patient and the patient is fatigued by breathing on their own. Soon he is going to be in tachypnea and he is going to start sweating so much and you will get all sorts of alarm. Also your patient will be agitated completely. In such scenarios you need to check whether the pressure support that you have given is enough for that patient or not. If not, you need to increase the pressure support level. Increase the inspiratory flow setting. Like I said, keeping lesser inspiratory flow always leads the patient to go in respiratory distress. We need to reach the demand of patient's inspiratory flow. Increase the FiO2 if there is low oxygen saturation, or administer pain medications or anxiety medications if indicated. This could be in cases where the patient is intolerable to pain. This could be from road traffic accident cases or a recent surgery. So when the pain kicks in, they are going to start fighting the ventilator. So in such cases analgesia can be given, or the whatever medications are required can be given. And then coming to apnea alarm, this is a very important alarm, usually backed up by a backup mode. So let's see what needs to be done in apnea alarm. Usually we are keeping a setting of 20 seconds. Now if your patient is not going to breathe for the time of 20 seconds, what is going to happen is apnea alarm is going to get activated. Where you can see this apnea alarm, it is most commonly seen when the patient is in pressure support mode of ventilation, when you are giving spontaneous breathing trials. So what is going to happen is the ventilator is going to detect whether the patient is breathing or not, and if for straight 20 minutes it detects that the patient is not breathing, that means the ventilator is going to go to backup mode that you have set. So the first thing that needs to be checked is check for leak or disconnection in the circuit. If there is disconnection, even though the patient breathes, the ventilator is not going to sense. So check for this, whether there is disconnection or any leaks. Increase the amount of ventilator support. Maybe the support that you are giving to the patient is not enough. Due to that, the patient might be going into apnea. Or adjust the sensitivity setting. Also many times this can be seen if ideally we set between 15 to 20 seconds of apnea. Now if we have set 5 seconds of apnea time, what will happen is the patient might be still taking the breath, and for that 5 seconds the patient didn't breathe, the ventilator will think okay, the patient is going into apnea, and the alarm will start getting activated. So you need to check whether the apnea settings are set properly or not. And then there are PEEP alarms. Now PEEP alarms can be either high PEEP alarm or low PEEP alarm. Now high PEEP alarm in mechanical ventilation is triggered whenever the level of PEEP exceeds a preset high PEEP limit. Now in such cases, if the patient needs that amount of PEEP, then definitely you need to go and alter the alarm settings for PEEP. But if the patient is not requiring that high PEEP and still there is some auto triggering happening, then we need to troubleshoot it. And a low PEEP alarm is usually triggered when the PEEP falls below the preset value. Imagine the lower limit of PEEP is kept at 3 centimeters of water, and currently the low PEEP alarm is seen. That means there could be some disconnection or some dislodgement, so we need to go and troubleshoot that. So we have seen so many alarm situations now with the various case scenarios and what could cause it and how we can troubleshoot it. So overall I would like to say is, whatever alarms you hear, definitely you need to go and troubleshoot it rather than just silencing it, because if you are going to silence the alarm, it might cost you that patient's life. The first step in solving any problem is to carefully analyze the situation at hand. The next step is to gather and assess the data, which should point to a number of viable solutions. If you are not going to the patient bedside, you are not going to know what is the thing that is causing it. But if you go to the bedside, definitely you will get n number of reasons because of which the alarm might be there. If you have any doubts, please contact me, or these are the references that you can go back to and read for enhanced reading. And thank you.